Good morning, everyone. Welcome back to our next episode of our ACS Can Coffee Club. I'm Doug Flora. I get to be the moderator today again, and we're glad to have you. As you know, the ACS Can is the leading nonprofit, nonpartisan arm of ACS, and we're here to talk about issues that are important to state advocates across the Commonwealth, as well as other cancer fighters. And I see some familiar faces on the line, and thank you all for coming back month after month. We see Dwarf Fighters here. We've decided we're going to get you on camera. She's going to be our guest next month, I think, right? Is that true? We'll see. We have some special guests today. We have Emily Messerly, who comes to us from the Kentucky Department of Health, where she manages the immunization branch of the Division of Epidemiology. She's a former reformed nurse practitioner who's now doing public policy and running things at the state level. We also have Alicia Gissenhuis. She goes by Alicia traditionally. No, she doesn't. It's always Alicia. And she's here as a PharmD with as a board certified oncology pharmacist who's been instrumental in helping take care of cancer patients at St. Elizabeth for some time, but also on the front lines in terms of the COVID vaccine administration. She can help us with some of the science on the shots themselves. And I'm a practicing medical oncologist, so I'll weigh in terms of some of the stuff that we're seeing in my office and things that are important to the patients that I'm seeing in my clinic. So, you know, as we set the table for today's discussion, obviously there are lots and lots of things flying around in terms of these vaccines. We have 2 commercially available, potentially a third on Friday, and I think Alicia can speak to that as the J&J is up for review this week and is anticipated that it will get prompt approval. We have some news that Emily can share with us about the rollouts across the Commonwealth, and I think we'll all be glad to hear those because we're sort of waiting for this phase 1C announcement. And then we'll talk on some of the issues in terms of disinformation and some of the myths that we'd like to debunk for folks out there who are talking to patients or patients who are considering getting shots, but are concerned about things that they found in the media. So maybe we start today with Alicia. And I think probably it's important that we talk about the vaccine itself before we talk about how do you get it. So maybe can you describe, and I think one of the things that we hear a lot in the office, major concerns is how fast this thing got to market and how quickly, and did the FDA skip steps in approval? Maybe you could speak to why we as medical professionals feel pretty comfortable with these injections.
Yeah, so great question. I think to answer that, we have to set the stage really of how vaccines work. So just quickly, I'm sure many of us know this information, but vaccines work by allowing our body to safely preview an infection or a disease. And we can do so in a couple different ways. We can take the actual infection or disease and we can weaken it. These are typically called live attenuated meaning weakened vaccines. Or we can take an inactive piece of the disease or the infection, and both of those is what we use in the vaccine. And then ultimately, when we inject that into the patient or into the person, we want to see an antibody response from your immune system. So your immune system will look at what we've given it and start creating antibodies that really serve 2 purposes. One, to be able to acutely fight whatever disease or infection that is. And then secondly, to create what is that smaller group of antibodies that will continue to patrol in your body. If it should come into contact with that disease or infection again, then it can create that response that is faster and stronger that second time around. Now, to Dr. Flora's main question is, what's different about these vaccines and how did they come to the market so quickly? So what's different about them is that they are what's called mRNA. M simply stands for messenger. And the best way to think about this is we looked at the COVID-19 virus and we were able to take a set of instructions for your immune system. And the language of those instructions is in mRNA. We put that into the vaccine, and then when we inject it, your immune system will take those instructions, read them, and start creating those antibodies like we talked about with those 2 similar purposes, that acute fight, and then also leaving that memory group behind to remember COVID-19 should it come into contact again. Coming along with mRNA vaccines, we have to remember 2 things. First and foremost, when your body is finished with the mRNA, just like you at home, if you were using instructions to build a play set for your children, a dresser, a bookcase, once you're finished with those instructions, you're likely tossing them and your body's going to do the same thing. Once it's finished with the mRNA, it's going to get rid of it. Secondly, it is a 2-dose series. The first dose, we are seeing some preliminary data for the 2 mRNA vaccines that there is some effectiveness. However, that first dose is not where we want it in terms of the antibody response being as large or as durable as we think is needed. So that second dose is very important in terms of getting us up to that immune response that we want. Now, the root of the question really is, how did they come to market so fast? Did they cut corners? What do we know in terms of safety and efficacy? Did they do everything correctly? It's a great question, and the observation is correct. They did come to market pretty quickly, but they did so through the same process that all vaccines and all drugs go through. So these are things like preclinical trials, phase 1, which is usually a smaller group of patients, really looking at safety and effectiveness a little bit. Phase 2, so a bigger group of patients, again, moving into a little more effectiveness as well as safety. And then phase 3, so a large group of patients. So to put it into perspective, over 60,000 for the currently available vaccines were studied in terms of efficacy. So how well does it work? And always looking at safety. So from these phase 1 through 3 trials, 3 usually being the next to last step before approval, but through the 1 through 3, the FDA issued what's called an emergency use authorization, or EUA. This is not the typical full drug approval. That's important to keep in mind. It is well named in the fact that the FDA felt that the emergent situation, the global pandemic, and the fact that we really didn't have any other treatment or prevention options warranted this issuance of an EUA, which, keep in mind, can be revoked or approved at any time. So now thinking through this one more step, right? We went through the 3 phases, but we felt like we did that so quickly. How could we do that? Again, great observation, and it's a multitude of reasons. I think first and foremost, our technology has skyrocketed in terms of looking at this virus and pulling those mRNA instructions and putting it into the vaccine. We're able to do that quicker. I heard a really great analogy the other day that doing an mRNA vaccine is like typing an email and hitting send. Some of our other vaccines, it's like snail mail. You're writing a letter, you have to put it in the envelope, take it to the mailbox or take it to the post office and mail it. So that's a great advancement in technology, but same final purpose in terms of efficacy and safety. Also, disease prevalence is high. If there's a silver lining to that, it's the fact that we can find benefit more quickly and more widely. Third, we had a lot of patients who wanted to be included in the clinical trials and they were eligible, so we could conduct enrollment faster. And probably one of the most important aspects of how it came to market so quickly is the manufacturers did an excellent job and started manufacturing these vaccines even prior to receiving the emergency use authorization. So once they received that, they really hit the ground running and shipped almost next day.
Alicia, I'm sorry you were on mute for all that. Can you repeat?
Should I start from the top?
No, I'm just kidding. Thank you. That's very informative. I like to mess with Alicia. She's a close personal friend, so I can joke with her. I wouldn't do that with Emily yet, but we might. So maybe moving to the state level, Em, you're in charge of a lot of these things, and you know, we see the CDC data, we see the published data putting Kentucky about 35th in terms of percentages of vaccines distributed. I think it's great that we got maybe 83, 84% of the vaccines that you guys have received out into people's arms. Maybe you can speak to some of the barriers, because I think there's some impatience, and many lay people who don't do what you do for a living may not understand that this is the largest public health initiative in the history of the human race. I mean, we need billions of vaccines in hundreds of countries and thousands of municipalities. So maybe speak to a day in your life and some of the things that you guys are tackling at the state level.
Sure. So thank you so much for inviting me to be here today. Yes, so you hit it on the head, Dr. Flora. Right now, the biggest issue that we are facing is it's a supply and demand issue. We definitely have, we're so happy at how much demand there is, and we are working with the federal government as far as demand, or as far as supply. Now, we do know if you all visit our kycovid19.gov website, we are very transparent with how many vaccines we receive in the state of Kentucky every week. And we are also very transparent about what percentage of vaccine is getting out there. Our commissioner, Dr. Stack, and our governor have put a call out to every provider that they get 90% of vaccine out within 7 days. Now, of course, the snowstorm last week caused some bumps there. And then we really have a very evidence-based phasing, meaning we utilized the Advisory Committee on Immunization Practices guidelines for who is the most vulnerable and who should receive vaccine first. So as you've seen, we've rolled out the vaccine to phase 1A and 1B, and we are still continuing to vaccinate those within 1A and 1B. So 1A are those healthcare workers, as well as the long-term care facilities. So we partnered on a federal level with Walgreens and CVS, and they went into every long-term care, assisted living, and independent living facility. And I want to call out, Alicia, how much throughout this pandemic response we have partnered with pharmacies and are extremely grateful for our pharmacy partners as they roll out vaccine in our state. So we have vaccinated the great majority of long-term care facilities already. That's phase 1A, healthcare workers as well. And when I say healthcare workers, that's anyone who works in a facility. That is not just doctors and nurses, that is anyone who works within the hospital walls, within the clinic walls. So we made sure that that was communicated. And then phase 1B is basically age. So 70 and above, and first responders being paramedics, EMTs, firefighters, those that are first on the scene. And then Governor Beshear and his lieutenant governor, they really prioritized our K through 12 personnel, and also have added childcare. And that program has really pretty much been completed already. And I'm happy to see that we are allowing more schools to open up next month. So as of next week, we anticipate being in phase 1C. And so phase 1C for anyone within Alicia or Dr. Flora's practice, although the list is posted alphabetically, patients with cancer are at the top of the list. We know the morbidity and mortality from heart disease and cancer in the United States, as well as in Kentucky. And so phase 1C prioritizes all individuals who have a cancer diagnosis to receive vaccine, regardless of age. So the phase C is anyone 60 and above, but it's also anyone over the age of 16, because it's not approved, over the age of 16 with any of the chronic conditions listed as having a higher chance of death from COVID-19. So cancer is on there, chronic kidney disease, chronic obstructive pulmonary disease, Down syndrome, heart conditions, any immunocompromised. Obesity is actually on there as well. Pregnancy is on there. I was working, I'm so happy to be seeing pregnant women receiving the vaccine. I saw two pregnant women recently in a vaccine clinic where I volunteered who were receiving the vaccine. And I said, please wear your sticker and show others that it is safe for a pregnant woman to get the vaccine. And then sickle cell and diabetes are the other two. So that's our phased approach, and we are going into phase 1C very soon. And I don't know if this would be a good time or if I should do it at the end of the call. I want all of Kentuckians to know where you can actually go to get a vaccine. This has been a question that we receive every day. Well, can I just get this vaccine from Dr. Flora? Does he have vaccine in his office? Well, unfortunately, no, he does not, but his hospital does, St. Elizabeth's does. So, and they're part of our map. So we have a map of all providers that are receiving vaccine across the state. And each of those providers have their own sign up, meaning a telephone number or a website where you can go to sign up to get the vaccine. So I'd like to share my screen with you all and just show you that website so you know exactly where to go. Okay, can you all see that now? Okay, so, oops, okay. This was semi-intentional. So if you notice right now, the website's in Spanish. I actually have in my practice some Spanish-speaking patients. So our website is translatable into, look how many languages you can pick for it. So that's really important to know. I'll put it back into English. So here's English. And if you go to our home page, right there in the middle, where can I get vaccinated? And so if you click on here, learn more, you will see that, here it says phase 1A and 1B. They'll be updating that once we officially go into phase 1C. But you can see this map here of all of our sites, and you can actually pick, the county that you live in. Now, those sites might not look like a lot, but then look down here. We have Kroger, we have Walgreens, we have Walmart, and then we have a list of independent pharmacies on a federal program, although we don't have them on a map. So I want to encourage you to send your friends and family members to this map, because this is where you can go to receive the vaccine. Thank you.
That's great. Your answer was so much more informative than Alicia's.
It can be a long morning.
No. It's you have to know. No, she set the framework.
Yep.
You know, you have to know how the vaccine works and how it affects your body before you go to make the appointment. So what she said was very important.
She'll never come back now. I'm just teasing.
Mm-hmm.
So guys in the clinic, this is interesting. So obviously one of the things that both of these practitioners are combating is the disinformation that I mentioned earlier. We know obviously that, it's a divisive time politically. This probably is not an issue that really deserved that, but it's 2021 and we understand the real world. Part of what we do with things like this is try and address disinformation with science. So one of the things that my patients talk about is videos that were widely circulated on social media of nurses fainting or passing out right after vaccines, or somewhat overhyped or overblown issues with regards to allergic reactions, which are nearly unheard of. It's 11 per million for the Pfizer version, and a little bit less, maybe 2.5 per million for Moderna. So these aren't material things, but they can be so overblown on social media these days. I guess for Alicia, maybe as we talk through this, can you talk about real side effects and what people can actually expect? I'm particularly worried that people are getting spooked by all the drama related to second shot, especially the Moderna with the Moderna arm, and maybe if you can put that in context. Remember, the math here is: do I wish to have long-term complications of COVID or death, or the side effects that are actually being seen?
Right.
And nobody wants side effects. I've had my second shot and I've sailed through it. So I was fortunate. I've worked with a lot of folks who weren't as fortunate, who had fevers and chills and cruddy stuff. So maybe you can fill us in on the data with regards to what we might expect with the shots.
Yeah, so great point. I know a very commonly asked question, and a reason we are seeing some patients avoid the vaccine. I think the biggest takeaway from this is that everybody is going to handle these vaccines differently, not only in regards to effectiveness, but as you mentioned, in terms of side effects. So just like patients who are going through chemotherapy, immunotherapy, radiation, stem cell transplant, everybody has a different experience. And also keeping in mind that having no side effects is normal. Having side effects, per the literature, is also normal. So side effects are not necessarily telling in any way of how well the drug is working. So keeping that in mind, there are some theories, but we don't have the data yet to tell us that. So I would say in clinical practice, these are very well tolerated. Like I said, I'm in clinic a minimum of 1 day a week at St. Elizabeth. We're giving right around 1,000 to 1,200 a day. So we're seeing a lot of patients move through, and overall, these are well tolerated. In the literature, what we can see, and again, there's that difference between dose 1 and dose 2, but the biggest side effects that were cited from the literature were things like fatigue or feeling tired, headache, chills, and then the arthralgias, myalgias, or bone and muscle pain with specifically the Moderna product. Now, in terms of from dose 1 to dose 2, these things did increase in the trials, but it's important to remember the reason why they likely increase. So keeping in mind what we talked about at the beginning, when we give a vaccine, the goal is for your body to be able to preview an infection or a disease. It's creating that antibody group, and that smaller group is hanging around, continuously patrolling. So now we're giving a second dose of vaccine, and your body is primed and ready. So likely what these side effects that we're seeing is more of the immune response to that second dose. So did we see an increase in the literature? We did. So fatigue or feeling tired increased by about 10%. Headache, again, was about 10%. Chills, a little more. It about doubled. And then the arthralgias, myalgias were probably most impressive. So about 4 times more patients did have that bone and muscle pain with the Moderna product specifically. But what's most important too to call out is that these side effects, they should not mimic symptoms of COVID in terms of some of those routine symptoms we're hearing. Things like loss of taste, loss of smell, congestion, cough. Those would be a reason to seek care from your provider. It could be an exposure to COVID, in which case you would want to seek emergency medical attention.
Okay. Well, I will say maybe I think that providers can lead by example here. And I've asked, and a lot of our colleagues have shared on social media when we got our shots as physicians or nurse practitioners or providers. I'll tell you, here at St. Elizabeth, we have about 9,600 employees. And it's remarkable how different the uptake is in our own employee population in terms of vaccination. So of physicians, 87% of people wanted the vaccine immediately. And we're vaccinated. 99% of people who got vaccine 1 got vaccine 2 in the physician subset of our group. But for other employees, and I think a lot of the non-patient facing areas, our average was closer to 53%. And so that's a gap, I think, for us in terms of internally mirroring what's happening out in the regular world, and that there are still people with concern out there, even though they have access to the vaccine, they're not taking it. So that's important for us. That's important for us on this call, because that means that there are eligible people out there who could be protected, who for other reasons that are disparate, and some of these that we've touched on aren't getting the shots. And that hits the other reason that we're all concerned, is that we can't reach this herd immunity. We can't fully open the economy. We can't make people relax around loved ones until we've vaccinated a greater proportion of the population. And at the current pace, the estimates are that we may not reach that until late summer or later, depending upon the uptake. So hence the reason for doing projects like this. Emily, I had a quick follow-up for you on the phase 1C rollout. And I won't put you on the spot in terms of dates unless you're comfortable releasing those dates, because I know this is all managed at the governor's level. Rumors are rampant that it's next week. So I'll just put that out there and you don't have to comment. Is there going to be an age requirement in the 1C rollout? Because we had heard rumors that it might be 60 plus at first, which doesn't really jive well with bone marrow transplant patients who might be 38 at grave risk versus a healthy 60.
So if you see and visit our website, phase 1C does clearly say that anyone 60 and above in phase 1C, when we anticipate it opening up in the near future. Phase 1C also says anyone 16 and above with those lists of diagnoses. So if you are 16 and above and you have any of those diagnoses listed on there, you are eligible. So there are a wide variety of clinical conditions which put you at higher risk for COVID-19 and severe outcomes from COVID-19. So it is not age-based, it is diagnosis-based. So that I did want to clarify that. I also wanted to clarify that when I spoke earlier about having seen some pregnant women in clinics, please know that those pregnant women did speak closely with their obstetric provider before deciding to receive the vaccine. So that is something that's very important, just as Dr. Flora's patients would do, as they would consult with him. Patients will consult with their pharmacist about the safety of getting a vaccine, but certainly any woman who is pregnant or breastfeeding should consult with their obstetrician or nurse midwife. Thank you.
Great. That's reassuring, and I appreciate you clarifying, because that was concern that the providers had heard rumor-wise. So it's really nice to hear that directly from you guys at the state level. I do think that's a pretty good idea here as a disclaimer. We do want this to be shared decision-making between you and your providers. We want you to encourage that if you're involving yourselves in patients' lives, if you're patient advocates, if you're speaking at functions or webinars or where things like this. I think I can comfortably say that the governing bodies of cancer patients, the American Society of Clinical Oncology, the National Comprehensive Cancer Network, ASTRO, which governs radiation oncology, and ASH, which governs hematology and bone marrow transplant sort of populations, have all universally endorsed this for cancer patients, almost without exception. And the only exceptions I would call out, and Chris or Alicia might be able to help us a little bit with some of these who might not want them immediately. There are some recent stipulations that maybe if you've had a bone marrow transplant, you want to wait 100 days because we're not sure that a vaccine works in that first 100 days, and you might be falsely reassured. And there are some nuances that we really want you to discuss with your oncologist if you are patients about timing. So we may not want to give the shot while your platelets are very, very low because it goes in a muscle. We may wait until you've recovered a neutrophil count from a dose of intense chemotherapy. We may not want to give it within the first 7 days of induction therapies for leukemic patients. So there are some stipulations. This is a broad general topic that we're discussing in this forum to encourage those discussions, but not necessarily we're making recommendations. I'd like my patients to come to me and we talk about it all day in clinic, and they have all of the same questions. And so there is there's some nuance to this. It's not all just go run and get your vaccine right now. So maybe, Alicia, that's a good transition for you to talk to us a little bit about current recommendations. We got these about 2 weeks ago from ASCO and NCCN, and maybe you can speak to specifically the risks for cancer patients who get COVID, because that's where we start. Is if I'm at perceived higher risk, maybe I should even be more enthusiastic about chasing down a vaccine.
Mm-hmm. Yeah, so all good questions, and I think the hardest part of answering this is if you look at the initial clinical trials, any patients who were receiving immunosuppressive treatments, and this affects cancer patients who were receiving chemotherapy, even patients like rheumatoid arthritis who may have received immunosuppressive therapy, high dose steroids, they were all excluded from the trials. That's tough because we can't necessarily apply what we learned from the trials to these patient populations. But I can say I was texting Dr. Dan Flora this morning to say, how can we start collecting this data? Because as we mentioned in the beginning, we can get the data quickly, and we see a separation in those curves that we see in the trials for efficacy or effectiveness very quickly. So we would love to be able to see those same things with cancer patients. And just as Dr. Flora mentioned, between ASCO, NCCN, ASH, ASTRO, it really states for the majority of our solid tumor patients, breast cancer patients on hormone therapy, patients undergoing radiation, that they should receive the vaccine when available. What you have to weigh in terms of risk benefit, as Dr. Flora already alluded to, is we know the chance of mortality is about double for oncology patients. So even though, many patients will live through it, and what then we have to consider, what are some of those long-term complications? I think we're seeing a lot of them in the news. So what happens after, a 30, 60, 90-day ICU stay? After a ventilator, what type of help at home are these patients going to require should, they live through COVID-19? So it is important to weigh the risk benefit, and ultimately for our cancer patients to remember that because we don't know the effectiveness yet, we still presume these to be safe and have some sort of efficacy. It's definitely a provider discussion for the decision of when this will be most effective for you. So keep that in mind and really talk to your provider. We do think these are safe, effectiveness we're still waiting for some data. So it is crucial that our patients continue to social distance, wear their mask, wash their hands, even after vaccination, first and second dose.
Can't echo that last point enough. And we got some questions in the chat about that. All of us, regardless of our immunosufficiency, can still shed virus after vaccination, even after second vaccination, even after fully vaccinated. You can carry this thing probably in lower quantities, hopefully, because you do have those memory cells that Leach has alluded to. But it's a really important caveat to point out that we're not yet sure that if you're a cancer patient receiving immunosuppressive therapy, that you're going to mount that immune response that you think you have. And since it isn't studied, what we're telling our own patients is you just have to act as if you haven't been vaccinated and feel blessed that you got it. Because we just don't know. And that data will be coming out. She mentioned Dan Flores, my brother, who's an oncologist that runs our research here and has really been tracking the COVID patients specifically and has published a few papers and presented on this with our research group. They're doing a great job on that. One of the things, I think we probably have about time for maybe 2 or 3 more questions, and I'll try and get to some of those. Emily, one of the things I'm most concerned about is that obviously it's very easy if you're a white physician in a hospital system to get a shot, right? But we're missing lots of ethnic and racial disparate populations. I love that you had all the translations on there because non-English speaking patients are at risk. You deal with a lot of patients in rural Appalachian communities. What are we looking at the state level in terms of reaching these persons of color or people who are socioeconomically disadvantaged to make sure that everyone has equal access to the shot?
So yes, we are working right now with our current sites to ensure that for the time being that no one is within more than an hour's drive to get a vaccine, but that is decreasing by the moment. We have, as I showed on the list, we have not only our large vaccination sites, we also have a large a battalion of pharmacies across the state. They are, as I showed you, we have Walmarts, we have Kroger's, we have Walgreens. Walgreens actually has the largest footprint in our state, and not just any pharmacy, I mean, not just Walgreens, but in the United States, in America, 93%, and this is in the CDC's playbook for COVID-19, 93% of Americans live within 5 miles of a pharmacy. So we are, the federal government and our state, we are really utilizing our pharmacy partners across the state to add more and more sites. And the federal government is adding more and more sites. Additionally, the federal government is partnering with our federally qualified healthcare centers who see 60% or more of their population is persons of color or of limited English proficiency. And FQHCs are now being added to the federal program where they receive a separate allocation of vaccine. And that is a program that has just been rolled out last week. And we will see more and more of those federally qualified healthcare centers across the state show up as providers.
Great. I think you've talked about that bullwhip of going between supply and demand, and we may be entering a phase in coming months as Novartis and Sanofi are starting to produce the Pfizer vaccine, as the Johnson & Johnson equivalent hopefully will be approved shortly, we think, we hope. They haven't released the data for us to review that yet. We may ultimately be at a position where we can start to immunize all comers. And I think we need to place a specific emphasis on caregivers and folks who are in homes of patients who are immunosuppressed. So for those of you that are on that list or have impact on people who are on that list, that's a group that we're already recommending to find this. My wife is a prime example. She's been trying desperately to find a shot for a month. I think today she gets hers on a Pfizer trial through Cincinnati Children's Hospital that was enrolling people between 12 and 50, and she's 50. So she's right there. So it's going to be nice when other folks can get access to this, because I feel a little guilty that I've had my 2 shots and I know I'm patient facing, but I also know that other people are deserving and worried too. So maybe as we look forward into the future in the coming months and we have a greater availability, Emily, can you speak to how we might address future public health issues like this? So we found ourselves short-funded, underfunded, underorganized, and thankfully people like yourselves have dedicated yourselves to public health. But we've created a sort of a morass here that we are not able to distribute these things because we didn't have the infrastructure ready. And so some of this is policy stuff, and there are some legislators and policymakers on the call and a lot of advocates. What can we do at the state level to try and help you guys?
So thank you for that question. All of it is related to funding, and we are looking to the federal government for additional funding for the infrastructure. FEMA also has provided us with some funding. So those are the two largest entities that we depend on for funding. So whenever FEMA or CDC funding come up for votes, those are definitely the two entities that are supporting public health throughout this. And I do want to note, you said your wife is 50. So based on our next phase, so the very next phase that we go into is purely age-based. So the next phase is anyone 40 and above. We don't know based on availability when we'll be able to open it up to that phase, but anyone 40 and above is the next phase. The governor and Dr. Stack decided to make our gating criteria much easier as we go through the phases and just have it really be age-based. So we go from age 60 at 1C, then we go to age 40, and then it's any adult 16 and above. But 1C, we will be in 1C for quite a while. That is a large chunk of the population in Kentucky, and we will be working to reach all of those individuals.
That's great. Thank you guys both for this. I think we're out of time. I know there are a number of topics we haven't gotten to, and we should. If you have additional questions for either of our discussants or for me, feel free to type them in the chat. We'll try and get back to you after the call. And we'll try and share this link for those of you that couldn't see all of it or wish to or would like to share it. So thank you all for joining us for this episode. We'll be back next month with another topic, hopefully is equally engaging guests. You guys have been great. And thank you for sharing your wide birth of knowledge with the rest of us. It's been good. Thank you all for attending, and see you soon.